Good evening, everyone, and thanks, Alok, for the kind introduction. I think I'm so happy to see the POCUS spreading, and Alok has taken this important aspect of lung ultrasound as a major breakthrough as a 3-month session. And I got the feedback, actually. I spoke with one of the members just a half an hour before, and basically the Surjit and Jafar told me that Alok is one of the best speakers, one of the best influential person in this module, and he has taken this lung. It's very, very well. So I'm very, very happy that we all as a team spreading the POCUS as the part and parcel of our thought process in the last 4 years. So Alok, just let me know whether my slides are visible and I'm audible.
Yes, sir. Visible and audible, sir. Okay,
thank you, friends. So I think I know almost 50% of the participants, which our NeoPOCUS and NeoPulse family, which we started this family since COVID times. You all know, or few of you don't know, I come from the India, and the city is a Pune, which was the capital of India for almost a century, 17th century. And the Pune is a cultural and academic capital of India. Most of the people would love to do education in the Pune city. And that's the place where we have the capital place, which is called as Shaniwarwada. So without wasting time, friends, what I'm going to cover in the first, I know you have done wonderful work, but I will cover in the first 15-20 minutes is a still basic revision, which I want to build up for a pneumonia sessions. I also know that a lot of you are doing excellent work in RDS, TTM, pulmonary hemorrhage, all sorts of pneumothorax, effusions, which is a part and wonderful work for basically the point of care lung ultrasound as the Western people. But I also understand that when it comes to the pneumonia and the parts of the pneumonia, you will see mainly a lot of patients are in Asia and Africa. That's what I'm going to concentrate, what we see in day-to-day practice and how we are doing something different than the others in few aspects. Because we all are well versed with the basics of lung ultrasound with the 6 regions. I'll come to that point. But we are going to go ahead one step ahead, and I will tell what my team itself is doing. My team means I come from the Bharati Vidyapeeth University Medical College, which is one of the deemed university in India. And my team is focusing a lot on the POCUS and hemodynamics research. I will also show you that what are the aspects they have done. Okay, this part I don't have to tell all of you, those who have joined, because most of you have joined, they are interested people in the POCUS. But only one request I want to all of you. Please always correlate clinical history examination to POCUS. That means, please think, what is your differential diagnosis in your mind before just jumping on the POCUS? You should have that question in your mind, which is going to give answer by POCUS. That is very important. Just directly don't say that I have done the ultrasound. Please correlate history examination. That is my first request. We all know as a POCUS is a focused bedside, real-time, serial for functions and for physiology understanding. We take action. And then we target treatment on that basis. It could be the diagnostic or functional. We'll come to that points when we thought. This is the design for us. We have designed for the Indian setups that focus for diagnosis, for critical assessment, for screening, monitoring, prognosis, procedure, and therapeutic. But my main thought process or my main request to all my colleagues, which I'm trying for last 5 years, is a research, collaborations, and putting all data together. That is what we all should work in the future and in day-to-day practice. So what I'm trying to say that we all know about the functional echo, which is a part of the cardiac focus. The brain ultrasound is in there since 1990s. Echo is there since 2000. The lung ultrasound came very well. One of the best things to happen in the world for neonatology is the lung ultrasound since 2010. Wonderful articles, plenty of articles, and people are enjoying. Gut ultrasound is this decade. Lines procedure is also for this decade. And I always said about the research and training. So let's just to have a revise few points for the pneumonia, what we do. That is what I'm going to talk about that. We all know about the ultrasound, penetration of the beams, and getting backward those reflections on the screen and getting the image. When it comes to the image, we have basically the fluid is the best friend, what we all know, and the air is the biggest enemy. So these are the two words we should know. But what does mean by the lung ultrasound for pneumonia? We talk about the artifacts. This is nothing but the artifacts. So you already saw the artifacts of in your course curriculum as artifact of RDS, artifact of TTN, artifact of pulmonary hemorrhage or effusions or pneumothorax. You must have seen already the similar patterns of the artifact produced by the pleural line. So one thing is, remember, the pneumonia means artifact produced by that pleural line and getting some form of a picture, which we'll see in the next 45 minutes. Okay, you know that about the importance of the lung focus for diagnostic and therapeutic. This is what we designed, and we thought what could be the things can be done for India. Mainly, we are talking about the pneumonias. When it comes to the, okay, I'm talking India, or when it comes to Asia or Africa, this pneumonia is the first in my thought process. Whenever the baby comes for respiratory distress, remember this statement. Whenever the baby comes for respiratory distress, my first thought process comes in my mind, is it a pneumonia? Whether that is congenital pneumonia, whether it's community-acquired pneumonia, whether it's a late onset sepsis related to pneumonia, whether it is ventilator and associated pneumonia, or whether it is associated in the form of pneumonic effusions, empyemas, abscess, or atelectasis. I'll come to these steps. So friends, please remember, when you are in the West, now I must say that I was almost 6 years in Sydney, and our first diagnosis was, I have never hardly seen any early onset pneumonia or community acquired pneumonia in the West. But here, we always talk about infections and asphyxia, and that's what we are talking today as thought process. We also document this one part, which is ongoing research, that already we published a paper on the basis of clinical side, clinical pneumonia, X-ray pneumonia, and surfactant therapy. Now, one more research going on my unit now, diagnosis of pneumonia by lung ultrasound, giving surfactant and monitoring that lung ultrasound on daily basis, and resolution of that pneumonia after surfactant therapy along with antibiotics. Professor Sujata is doing this additional research from my unit is about diagnosing pneumonia, giving surfactant, and then resolution of that pneumonia on the lung ultrasound. I'm not talking about the X-ray. That is what currently one of the things I'll show you that the importance part. So we are talking about diagnosis and we are talking about functional aspect. That means therapeutic aspect. You all know therapeutic aspect or functional aspect as first dose of surfactant, second dose of surfactant, or extubation or recruitment of the lung. You must have seen the previous sessions, or the weaning. That's the functional aspect. When it comes to pneumonia, what functional aspect we are thinking is basically scanning the baby and documenting that lesions. I'll show you that one. So when you come to the pneumonias, there is a one difference what I'm going to tell you. What is additional points we are performing, I will tell you that one part. As you know, you are familiar with the linear probes. You're happy about that. You might use the curvilinear, but linear is one of the simple. But I think the best probe or good probe for pneumonias, if you have a feasibility, please buy this hockey stick probe. Why I will tell you that this small footprint with a higher resolution, you could able to diagnose those very well. So yes, linear has a big footprint. Then for smaller babies, it becomes very tough. Suppose I'm talking about 800-gram baby, this big of linear probe becomes very tough. Hence, please think about, if you have feasibility, please think about buying this hockey stick probe. That would be the better option for us. We all know about the probe. When we put this probe, most of the time you just put the perpendicular position. I will put one more step ahead. Yes, you scan through the perpendicular, but whenever you have a problem, if you found a problem into that scan as a pneumonia, I'll show you what is pneumonia. You please do the regions as a longitudinal also. So this is one more request from my side, or one more suggestion from my side for pneumonia. Once you have done the perpendicular, marker is up, but once you suppose I got a pneumonia in the basal or right posterior, immediately check the longitudinal area also. This is the marker, that is the probe position, that is the cranial side, while here the probe position is towards the parasternum or the sternum regions. That's the one additional point which I'm going to talk as the part. The one of the aspect, please remember, this probe has to be perpendicular to get the views. That is the most important. This is not the ideal one. Lateral is not ideal. You will struggle or you will have artifacts. So perpendicular to the chest, that's basically the axillary regions. These are the axillary and these are the anterior regions. So what I'm trying to say is that, please, this is the most important, perpendicular. That's the first thing when you talk about these ones. So these are the pictures. You can go through this wonderful article which explains about various regions. Naturally, you are seeing the regions on the right side, left side, and the lateral side. What is the one thing which I want you to concentrate now? You all know about the 6 regions approach. Right side 2, left side 2, axillary 2. Probably you have learned so far. But the one difference which I want to tell you that for pneumonia, please don't do 6 regions scan. You are going to miss the pneumonia if you do only 6 regions. This is the most important statement I'm making here. If you want to diagnose pneumonia, please do 12 region approach. What is the meaning of 12 region approach? The 12 region means you have to do the posterior scans. Anterior and lateral, you are not going to find out. The commonest place of the pneumonias are the posterior regions and the basal region. Your X-ray might look normal, or anterior and lateral region will look normal, but your posterior regions will come out with the pneumonia. And this is the common finding what we observed. And this is one more research, again, one of my team member, Professor Sujata, and her DM candidate, Dr. Aniruddha, they are working now that checking this posterior region, checking the basal region, that is the axillary additional region, which is mainly for basal pneumonia, and this 5 and 6 is for posterior regions. So what is my second message here? My second message is here, please do the 12 region approach to diagnose pneumonia. And this is applicable. This is applicable. What we are trying to say that this is applicable for basically pneumonias or the various aspects of the pneumonias, which is very important. Now, what we are doing here, I told you that you all know this 2 and 2, 4, and you do 1 and you do 1 here, which is a 6-region approach. This is a wonderful article written by one of the Neonates family member, Dr. Gunjana. You can go through this article, which is freely available as basically the severity and management of neonatal pneumonia. What is most important part here is that, okay, I want this lower basal region. I want this lower basal region and the posterior both. That means right posterior upper, right posterior lower, left posterior upper, and left posterior lower. These are mandatory regions for pneumonia and subsequent complications of pneumonia. I hope this is clear. The posterior regions are similar. Right upper posterior, basically right upper posterior, right lower posterior, left upper posterior, left, same thing, just you have to turn the baby. Yes, you have to turn the baby. But that's a matter of 1 minute. You just intubated, you are also, baby is intubated, you just turn one side and just do that scans perpendicular. That is the second message I want all of you, please do that. If you are not doing, you are going to miss the pneumonia. It is very clear cut. It is very clear cut. Hence, you should always document. You should always document your report, upper and lower of anterior, upper and lower lateral, upper and lower posterior. You all have seen the Bradt score. Professor Bradt has done upper, lower, lateral only once and no posterior. So you're seeing 3 on the right side and 3 on the left side, 6 regions. But the 6 regions are which is Bradt score is designed for RDS, BPD, those things. It is not designed for pneumonia. This is very important thing, please understand. And that is what I'm trying to tell you that. Okay, just a little bit about basics, anatomy and lines. Those ones repeat next 5 minutes. You all know, but still basic repetition. We all know the anatomy, skin, subcutaneous tissue, ribs, intercostal muscles, pleural line, parietal, visceral, and lung tissue. So when we put a probe, we have skin, subcutaneous tissue. We have the parietal and visceral pleura, and that's the pleural line we'll see. And we have these lungs, which is reflected, which will be reflected as an artifact on the pleural line. So when we see this as a grayscale, basically, if you see the grayscale, skin, subcutaneous tissue, ribs, intercostal muscles, this echogenic line, this is the echogenic line which we are talking, is the pleural line. And we see these artifacts. This is nothing but the mirror images, what we will end up with that as the day-to-day practice and the lung ultrasound. So pleural line is nothing but this hyperechoic 0.5 millimeter thick line located below the rib lines, and that indicates the parietal pleura. And that's basically what we are talking is the reflection, that is the pleural lung interface. This pleural line will have artifacts, and that artifacts basically which the lung moves on this pleural line, and that movement what we call as lung sliding. So we already talking about the pleural line and lung sliding because this pleural line gets disturbed, irregular into the pneumonia. That area becomes abnormal, or there will be the collection of the fluid. That's what I'm showing you, the pleural line. That area lung sliding gets abnormal. That is what the first thing what we see. We all know once you diagnose the pleural line, you will see such artifacts. These are the horizontal, equidistant, echogenic. These are the reflections. You can see the reflections, mirror images, and that is nothing but the A line. Naturally, in the pneumonia, that part of the lobe becomes as a mass homogeneous. We'll discuss that, and that's what the A lines goes off. Some part of the B lines, you must have seen patterns of the B lines in the previous classes. You must have seen the patterns of the various patterns of the B line. Just a small revision, which is not a part of discussion, but simple thing that these are the vertical echogenic lines till the bottom, and they are perpendicular to the pleural line. You can see now, these are the horizontal lines and these are the perpendicular lines. Lung sliding, this is the normal anatomy. This is the air and this is the fluid. That much you all know. But Once I talk about the plural A lines or B lines, we talk about the simple B lines, small amount of the fluid in the interstitium, where you could able to see the acoustic shadow of the ribs shadows are there, and the lines are segregated. These are simple lines. When we talk about the lines with no A lines are erased. In the previous image, you see that A lines are still there. Very tiny amount of the fluid, transitional circulation, TTM-like picture. But when the A lines are erased and the shadow is still there, the B line, that means fluid component is going up. Now you compare this A line pattern, which we always call as AIS pattern, that is fluid in the interstitium as well as the fluid in the alveoli. That's the AIS pattern we call. While this AIS pattern becomes as a whole compact fluid. You can compare this is like a rainy season of India. The rainy season, which we usually call as in the month of June to September or till October. Initial parts, you have small droplets of the rains. Very simple. 1-2 drops, 1-2 drops. That we can call simple B lines or compact B lines. When the rain goes up, that means fluid goes up, we can concentrate on AIS. And when there is a heavy rains, we can talk very heavy rains. You can't see it through and through. That is a compact B lines. So you can compare these simple things as a droplet rains, increased rains with the very heavy rains as the B line. That is how the fluid amount of the lung also goes up. That is what we are talking. And these are the ones you saw as a total whiteout. Most of the cases you must have seen this total whiteout as the part and parcel. If you compare this confluent versus AIS versus this one, for you just have to remember as the fluid quantity goes up. And that's the article I told you, again written by one of the NeoPOCUS family member, one of the DM candidates, Dr. Arjun Verma and Abhishek Paul from the third batch. They have written this wonderful lung ultrasound and emerging tool in critical air units. Again, the article is free. Please go through that article. All these basic concepts are covered into that as the B lines and all that. Now let's come back to this from basic physiology, basic anatomy. From basics, now let's jump to the pneumonia, which we all wanted, which we all thinking about considering this pneumonia as the part and parcel. Now, what I'm going to cover, we have various parts of pneumonias. That means you get congenital pneumonia as early onset sepsis. That is a very common presentation in Asia or Africa. We do get community acquired pneumonia, maybe coming on day 7, day 10, day 15, E. coli, or even staph. That's a community acquired pneumonia. We do get late onset sepsis with a lung involvement. We have VAP, ventilator associated pneumonia, or complications of those pneumonia in the form of a pneumonic effusion, which is very common in bacterial infection. Empyema, yes, we do see empyemas, not in the newborn immediately, but we do see in the first 3 months of life. This year we saw till infancy, a lot of empyemas. Basically, strep pneumonias, we saw a lot this year. And those are actually received the pneumococcal vaccine. And they have empyema this year in the infancy. Lung abscess. And then I'll discuss few points about diatelectasis. I already told you that this is one of the good articles written by Dr. Divya, who is the member was batch 4 to assess the severity of the pneumonia. And the members, Usha Devi, again member of NeoPOCUS family number 4, they have done wonderful work and came out with the simple thought process about these pneumonias. Now let's see the clinical features of the pneumonia. Okay, you all know clinically baby will present as a distress, baby will present as a hypoxia, hypoxic respiratory failure, desaturations, we need cyanosis. That's a simple thing, as you know. It could be the congenital, it could be the acquired, it could be the hospital acquired, or it could be the ventilated associated. So clinical presentation, you know, a pattern of respiratory distress. That's the first thing you know. Now, in that pattern of the respiratory distress with hypoxic respiratory failure, you might require ventilation. Whatever, if you require or not required, it is your choice. What is your protocol? Whether you are non-invasive, invasive, what is your protocol? And then you have done the 12 region scan. Now, what is the first important thing what we'll see? In the first important thing, we'll see that below that pleural line, we see this lung looking like liver, hepatization. It is called hepatization of lung. I'll show you those videos. So the first thing you see that your A lines are not there, your B lines are not there. This is a consolidated area we'll see, which is like a tissue, which is like a liver or spleen. That tissue is like a tissue-like structure is there. Hence, it is called as hepatization of lung. The term is hepatization of lung. The size could be small, size could be big, depending upon that hepatization. And in that size, you will see white dots. That is echogenic dots. In the terms of lung ultrasound, we call echogenic dots. They are moving in and out. It is called as air bronchogram. And that air bronchogram, when you see the moving in and out, it is called as a dynamic air bronchogram. That means air is going in and out. The boundary of this pneumonia is mostly irregular. And that is called as a shade sign. I'll come to this point. So 3 things you have to always check in these regions. We saw that regions 1, 2, 3, 4, 5, 6, one side, 6 another side, 12 regions. You have to see this area of hepatization. You have to check inside echogenic white dots which are moving in and out, which is called air bronchogram, which is dynamic air bronchogram. Static means they are there, they are not moving. Dynamic means they are moving. And the boundary of that hepatization, you will have to see it's irregular boundary. At the boundary, I'll show you that. At the boundary, you will be able to see the echogenic white dots. So those echogenic white dots are created like shade sign. Now remember one more important thing. This is below the pleural line, but that pleural line gets disturbed. It is irregular. And that area lung is not sliding. Now let's see how it looks like. So when you put the probe, I told you that put the probe perpendicular in 12 regions. You see now this area. Just now in this region, this area, you see the hepatization. I'll show the videos also. So this is the area where it is looking like hepatization. These white dots, these are air bronchogram, they'll be moving. And this is the boundary which is irregular. This is not regular boundary, this is irregular boundary with this shade sign. Shade sign means like papers, small shades you are making. So these papers are actually cut. That's the one. This side, where there is no pneumonia, you could see the pleural line. Here, pleural line is disturbed. There is no A lines here. That's gone. So that's what we'll concentrate now. Now see this baby. This is the right upper area. This is the right area. And in this right, actually, what we are talking here, now see this area. This is the area which is looking like liver. This area is looking like liver. These white dots, these are the shade sign. And these white dots inside, this is the air bronchogram. When you see the video, it will be more important. But the friend, what is here? I have done this right anterior and lower. This right anterior and lower was normal picture. Even though the X-ray is showing pneumonia. This picture we got in right posterior part. Right posterior part, we got this picture. If I would not have done the right posterior, naturally, X-ray is done, but we don't want to do X-ray in future. That's our aim. We have reduced 50% X-ray in my unit. If I would not have done the posterior scan, I would not have got this wonderful picture of the pneumonia. Now, all of you concentrate. Videos now. Now you will see that videos and then you compare this one. These are the pictures from my unit. This is the picture from one of the champion boy of POCUS. Dr. Rajendra, second batch member. We do have a lot of collection of these videos. Now just watch this area. Now this is the area which is the different area, but this area now just watch irregular boundaries. Watch this area which is looking like a liver and see these white dots. We are moving inside. These white dots, can you see these white dots which are moving? That is called as a dynamic air bronchogram. When they are not moving, it is called static air bronchogram. So first thing, what you need to see? You need to see this hepatization of lung. Second thing, you need to comment on air bronchogram. Third thing, see the borders, irregular shade sign. Fourth thing, check the pleural line. Pleural line is gone here. I can't see the pleural line. And naturally, this is the lower part. This is the posterior lower part. This is the right posterior. Right anterior upper and lower are normal. Here you can see the liver. Can you observe? Right posterior, this is a basal pneumonia. So friends, if I would not have done these pictures, I would have missed my pneumonia by doing 6 region scan. So what I'm trying to say? 6 region, wonderful concept, wonderful research. That's a standard of care for RDS, TTN, DPD, or hemorrhage on that, anything. But the 6th region is not for pneumonia. Please make this clear. You have to scan all the region. Then and then you pick up the pneumonia. I told you that the basal pneumonias are common. Hence, posterior area has to scan. This is another area. See, these are the B lines. You know that now. And see this area again. See this area. This is hepatization. See this shade sign. See this air is moving in and out. Pleural line is gone. Here pleural line is normal. So you have to identify. Why I have taken the basics? Because you all know pleural line. You all know this is like a liver tissue. And this liver tissue with irregular boundaries with the shades ... And these insides are air bronchogram. This is a classic pictures which I got from periphery of India. This is a community acquired pneumonia. Dr. Malvika from Neopocus 4th batch. This is Dr. Malvika from Neopocus 4th batch. Now see this big baby. This baby came on day 15 with severe distress, with hypoxia, saturations 83, 84, anterior scans normal, right upper, right lower, lateral normal. But see this massive pneumonia on the right posterior. Excuse me. Sorry, I have a habit of talking very loud. This is the picture of the posterior part. Right posterior, you see this whole area. Irregular boundaries, air bronchogram, fluid collection also. This is the fluid collection. Syn pneumonic effusion. So this baby with a community, this is a 15 days old baby, community acquired pneumonia. Community acquired pneumonia. See this one. This is wonderful pictures. So what I'm trying to say, friends, repeatedly, I'm repeating same thing. The lung is looking like liver. Boundary is irregular. Shade sign, air bronchogram. Here there is additional point, fluid collection. That is the importance of posterior region scan. And that's what I told you that thanks to my professor Sujata, she is working on that thesis. Once it is published, she will come out with the paper. Now, before that, now see this one. Sorry, the video is not running. This is the pneumonia. This is the air bronchogram, and this is the fluid collection. The fluid collection is exudate because there are white particles inside. It's exudative effusion. This is the collection, which is exudative effusion. And that's pneumonic effusion, commonly seen mainly in the bacterial infections. That's what we see. This is another very nice video I got from NeoPOCUS 4th member, Dr. Jayanta from Assam, India. This is a 4 months old baby. It is not a newborn. But see now this fluid. All of you will enjoy. Those who have not seen the pneumonia previously. This is the mass. This is the mass. This mass with this fluid, this is the ribs. And this rib has broken here. And this fluid, which is empyema, which is also going to subcutaneous tissue. Skin, subcutaneous tissue, ribs, pleural line I can't identify. This is a massive fluid collection, which is nothing but echogenic particles inside. So this is nothing but pneumonic effusion with empyema, and that fluid is now reaching to the subcutaneous. There is a breakdown here. I know the people in the West, they might not have seen this, but we do see these things in Asia, Africa. So this is called as a empyema necessitans. See the simple thing, and you can see the X-ray. X-ray, you can see, oh, there is a pneumonia. What your X-ray will say? Pneumonia. But ultrasound has shown this is not only pneumonia. This is pneumonic effusion. This is exudative effusion. This is empyema, and this is empyema necessitans. So we have gone one step ahead. We have reached to the classification of that. And that is important to document for all of us. I cannot say only this is only pneumonia. I cannot say that. I have to reach that point. That's very important. This is another picture from Dr. Gunjana, member from NeoPOCUS second batch. This is the classic echogenic boundaries. Clinical history was classic. Fever, persistent fever, persistent. Baby was ventilated. Klebsiella, fever persisted. And this is the picture with echogenic boundaries inside anechoic. You can see it's a lung abscess. So this is the varieties of the cases or patterns of the lung ultrasound in infections you can diagnose. That is what we are trying to say you that what these are the ones. Just now somebody asked me as the collection. This is the nematocele. This is what you see commonly in the staph or gram-negative sepsis in India, which is there, which we can see. So we saw classic pneumonia. We saw pneumonic effusion, which is exudative. Empyema necessitans, lung abscess. So this is what severity, this is what we have written the article that lung ultrasound for pneumonia. This is the proposed thought process from our side that pneumonia with hepatization, straight sign, air bronchogram, mild form on the lung ultrasound. Pneumonic effusion moderate, effusion with exudative particles moderate, empyema and lung abscess, and which I showed you step by step. That's what is very important, friends. Now let's see. This is what you do, or most of the people in the West, they all work with the RDS and TTM. Now see the simple images to compare. We know that there is a subpleural consolidation. We know the whiteout lung. We know the abnormal pleural line, classic of RDS. Fluid patterns, lung sliding present, double lung point as the TTM. But the classic hepatization with air bronchogram, with straight sign, is the hallmark of pneumonia. Now see these three images, then you will be happy to know that comparison white about these ones as this is one. I'll come back to the pleural effusion measurement, Surjit. Give me time, and then I will discuss about that measurements and the formula, which you all know. The meconium, which is common in India, which also presents similarly. That means you should know the clinical history. Meconium will also produce the same hepatization, air bronchogram, but in between in the other regions, you will find the normal lung also, which is called spared areas. But you should have a classic history of meconium. That's where clinical history is always important. So we'll work on that clinical history in our day-to-day practice. So this is what we are talking as the part and parcel at the meconium. This is why I always say that this is our lung scoring system or pattern. In our unit, we always talk about we always talk about the consolidation, because which is very important for all of us. And then the pleural effusion, because these are the part and parcels of Asia, Africa, where we do see more of these ones. That's what important. Now let's discuss about the pleural effusion or empyema, which is basically the complications of pneumonias, which we see common in infancy, but also sometimes as you can see non-immunized drops. But infective pathology, we are talking lots in infancy part, which you see as anechoic area. Anechoic area. Most commonly, you see the axillary part, which is very important. As you all know, kidney, liver, and lung and diaphragm. That's the axillary area. Marker is up. You can use the hockey stick rather than curvilinear. Curvilinear is also good, but hockey stick is the best. You can see this anechoic area. You can see this anechoic area. And this anechoic area with echogenic lung, which is floating in the fluid, that's a common finding, what you see, which is surrounded by a bow site. That means the collection of the fluid in the pleural line, and below is the lung parenchyma. That's how you can diagnose the pleural effusion. So these are the pictures or videos. Now these are all our bacterial one, because you can see this exudative transfusion. You can see this exudative transfusion here. You can see this exudate here, and the lung is floating inside. That's called as a Plapp's point. So this you must have heard. This is the lung which is floating inside, is a Plapp's point. But you can see surrounding part, which is anechoic part. Inside there are particles. Can you see these inside? These are particles. These are the white particles. Now for amount of the fluid, you can just freeze the image and measure the maximum pocket. Measure this maximum pocket. Measure the minimal pocket. Maximum plus minimal pocket multiplied by 70 is the fluid amount. Or if you take only maximum pocket multiplied by 90 is the amount of the fluid. I'll repeat this statement. You can take this maximum pocket or the maximum length in the longitudinal area, and this is the minimal pocket here, which is, you can add 1 plus 2 multiplied by 70. If you don't want to add, take this maximum pocket multiplied by 90. That's the amount of the fluid. The importance of the lung is that it is not only for diagnostic here, it is for therapeutic, which is very important in India. Now, I said in the last, today is the month of March, from Jan, February, March, in PICU, we had 10 babies with empyema, and by lung ultrasound, these are all infants. By lung ultrasound, we could able to do the thoracocentesis. And that is where you can see these complicated, these are nothing but the septations. We all know about the septations in the anywhere. We all know as septations, that means septations means bad. You have seen septations in the brain, septations in the heart. Similarly, septations in this pleural cavity. This is a complicated empyema. And naturally, you might ICD or further thoracoscopy with this one. That depends upon your clinical decision. So lung ultrasound is useful to categorize this. Lung ultrasound is useful not only to diagnose pneumonia, it will diagnose whether it is simple pneumonic effusion. That means you can able to treat with management of antibiotics. Or with such, you can't say only antibiotics will do here. You will require drainage or scopy in future if it's not required. So there is a quantification. That's the additional advantage of lung ultrasound. And it is, how much time it requires? It requires hardly good 5 minutes. I would say 2 minutes, but 5 minutes. You take 5 minutes for 12 regions. It is so nice, so easy, bedside. Immediately you could able to say on this basis that this baby is the very sick baby. We have gone one step ahead now, which is not yet applicable. Means we are keeping our ultrasound machine in OPD, and immediately we are scanning and finding out the pneumonias because we had a lot of adenovirus in Pune city. And adenovirus related pneumonias were very common in the last 6 months. We have able to screen those in the OPDs, and then we can go ahead with other investigation. But that's the future. That's the next step, what I'm talking to this. Now, just I mentioned that it is not only diagnosing this effusion. You required basically the simple thoracocentesis. Just you can see these lungs which are floating. You can put the needle and you can aspirate, send for diagnosis and send for therapeutic also. So the lung ultrasound is so nice for these infective pathologies, which I just showed you the various patterns. What more important for us is basically the pneumonic effusions, exudate effusions, empymas, and complicated empymas. Because you don't see such in the West. That's what basically we are talking more. And that's the reason Alok told me to talk on this area, because other areas your team has already covered in these areas. Now, one more area which you need to basically understand is atelectasis, because that is the one area which you will confused with the pneumonia. There are two important points here. It will look like hepatization. Pleural line abnormality will be there. Lung sliding absent will be there. A lines absent will be there. So similar like pneumonia, it is like that only. But the difference are two. The borders of that is clear. It is very clear borders of that hepatization. And the air will not be moving. This air will not be moving. It is a static. So it is very important. Yes, clinical history, very important. But the two important points are that there is increased blood flow. This area looks like as a solid mass. It will not, it is a regular mass. It will look like as a mass, as a solid with a clear boundaries, and air is not moving. So this is the mass. Can you see this is the mass? There is no shear sign. Clear boundaries, no shear sign. This air bronchogram is not moving, increased blood flow. Remember these 4 points. Please remember these 4 points. Because you have to differentiate pneumonia from atelectasis. Very important thing. Mass is there. Same thing. Hepatization is there. Both the cases, hepatization is there. There won't be effusion. Boundaries are clear. There won't be effusion. Boundaries are clear. Air bronchogram is static. Increased blood flow. These are the points what you should understand when we talk about these ones. So these are the points I have repeated. Congenital pneumonia, community acquired pneumonia, ventilated pneumonia, atelectasis. I'll just put one point. Congenital pneumonia, hardly will see effusion. Community acquired pneumonia, lot of time effusion. Hepatization, irregular shear sign, all they are there. Here, slightly difference point is effusion point. Ventilated, dynamic air bronchogram is all there. Dynamic air bronchogram will be all there. So we talk about ventilated. In the ventilated, there are multiple subpleural consolidation. There are multiple, they are not one, there are multiple areas. While in atelectasis, I told you, the boundaries are clear, no shear sign, no effusion, and static air bronchogram. That is what we talk about these ones. So friends, this is what I covered. Slightly, yes, you will require a lot of patience to observe. It is not one day. Focus is not one day. You will confuse yourself. But I tried simplified. I tried what we see in day-to-day practice. We need more data on that. And that's what we are trying to publish, that research. And this is what I'm talking, research. Without research and training is also very important, which we always talk. Can you see the lung ultrasound pictures or research from 2010? Before 2000 to 2000, hardly any articles. 2000 to 2020, can you see the number of articles per year? It has jumped. From 20 to 40 in the last, can you see in the last 3 years? almost 100 articles on lung ultrasound. You open the journal, you will see nice lung ultrasound article. You open the journal, you will see the lung ultrasound article. So research is jumping very well. That's happening. Friends, that's what we started Indian journey in the last 5 years. And my own team, thanks to all of them, they are all working in hemodynamics and POCUS. By this time now, we could able to publish almost 33 POCUS articles. This is the international guidelines. You must have, I think few of you gone through that one. And these are the POCUS crashing neonate. And I represented Asia in this group. Few of you have already made few of the consultants here in this, your lung module. So in the lung POCUS, what we are talking pneumothorax. But can you see these two important things here? Consolidation and effusions. Because you don't see too many these two things daily, but that's a part of your crashing neonate. You have to adjust naturally the maps and thoracentesis. That's a part and parcel of our training. So that's a crashing neonate protocol, which is lung ultrasound POCUS, which is a part and parcel of your training. These are the articles, please. They are freely available. You can go through that. POCUS lung, emerging tool, and pneumonia article also I told you. Alok can share all these articles. They are freely available. You just open the any platform, you'll get these ones. Nothing, they are free articles. This is what we talked about India. POCUS the way forward. And we are trying to design trainings and curriculums and lots going on. And we are really happy that a lot of Indian units are doing good work. People are going very well. And now, last 5 years, things have been changing. And that's what we started the journey of POCUS in India in the COVID times, from offline to online. And we could able to actually train a lot of people. We could able to publish. This is the book for the POCUS lung, which we also could able to write a lot of articles on the POCUS, not only the lungs, but various. And one of the innovations we have done, and we changed the world, as we all know, as an online training. And this was the first program in the world which we started as a NeoPOCUS. And that's a 6 months program, which we cover the brain, lung, functional echo, lines, procedures, and research. And very happy to tell you that we have members from now 22 countries of the world. And friends, so far so we have trained 290 members from the 6 months batches, and currently the 6th batch is ongoing. And definitely we are happy that all team members are contributing a lot, and a lot of images, videos you saw, all they are collection from all of them. Thanks to all of them for contributing so much knowledge to the world in the field of the POCUS, what we are working at present moment. This is the article along with Alok. Alok has taken the lead as the training and education. Does it really impact? And that's the article Alok has submitted currently, that impact of the online education on the lung ultrasound skill acquisition. We had a survey of almost 175 members from the 4 batches. That means 21, 22, 2021 and 2022. That means after the 1 year of lung ultrasound learning, we have collected the data. And what we found, that all these members are enjoying lung ultrasound, skills are improved, and acquisition of the images is improved, knowledge are improving. So a lot of people say that how this is happening online. A lot of people question marks. Ultrasound has to be learned bedside. We have said that yes, that's correct. But with the training methodologies, with the videos, with the procedure skills, we have shown with the mentorship, with the acquisition of images, with the revision of images, we have shown to the world that we can do ultrasound training, lung ultrasound training, brain ultrasound training, echocardiography online. And that's the article Alok has submitted to the Frontiers in Pediatric, along with the Gunjana, member of the 2nd and 3rd batch members. So friends, POCUS is the future, all we know. Lung ultrasound is a part and parcel. Simplest part is a lung ultrasound. The easiest part is lung ultrasound. And that's what we say, that bedside ultrasound is the future for the day-to-day practice. So friends, the allocated time, Alok told me the 60 minutes and then 50-minute discussion. So I will not take more time. I have already shoot out 1 minute more than my allocated time. Lung ultrasound is basically the integrated clinical history, very important. History examination is a part and parcel. It's an excellent tool for pneumonia, pneumonic effusion, empyema, complicated empyema, lung abscess. You can easily, wonderful monitor, and that's a need. Yes, for Asia, Africa, we cannot say that we don't know that. Serial ultrasound is very useful. It's like your stethoscope, do daily, very easy, don't charge. That need is very easy for us. It's a point of care, easy to learn, repeatable, and that's a future for all of us, that every clinician, every neonatologist has to learn lung ultrasound. There is no choice on that. With this, that's greetings from Pune. If anybody wants any articles, any material, any thought process, that's my email ID and that's my WhatsApp number. I'm always available. You all know, most of you know the members who have joined. I know personally most of them. Thank you. Thank you, Alok, for this wonderful team. And let's go through the discussion, which we can have that discussion. I'll stop here now from my side.
Thank you, Pradeep sir. A fantastic talk, and clearly lots of questions that are there on the group chat. So hugely beneficial for us to have you with us today. So as a first, we've got a question from Alberto Berenguer. Alberto, are you able to unmute yourself?
Yes, I am. Thank you very much. Yeah. Wonderful, wonderful presentation. Love it. So I didn't understand very well, but I would like to ask doctor about the difference between pneumatoceles and abscess. What are the ultrasound features which you can...
Okay, so fantastic. So again, what is happening at present moment is we are not able to reach to differentiate pneumatoceles and lung abscess. We are just showing at present moment, this could be pneumatocyl or this could be the lung abscess. Okay. The final diagnosis will be by CT scan only. Okay. But at least you can say that clinical presentation, baby's clinical appearance with such ecogenic mass with inside liquolucency, you can say that, oh, this is something, could be abscess, could be pneumatocyl, but ultimate definitely is the, because CT scan is the one, sometimes you have to take help, and that is what I would say at present moment.
Thank you very much.
Dr. Ashraf, you have a question. Are you able to unmute yourself?
Good evening. Thank you for wonderful talk. I have a couple of questions. Which of them I think it is time to add the lung segment in report for the pneumonia and the atelectasis to get exact location. The other thing, the pulmonary blood flow can found in atelectasis and consolidation.
So this is a point of a little bit of controversy in that various authors have kind of tried to discuss whether pulmonary blood flow vessels actually accurately differentiate consolidation atelectasis, and there's slightly different points of view. So we wanted to kind of pick your brains. What is your experience?
Okay. So first of all, if you want to pick up atelectasis, okay, remove the blood flow part. Let's first pick up on the atelectasis. Now, you all know your mind. That's what mind means, history and examination. Please remember that is always there. You have done the examination of that baby. Clinical history, you have done that examination. You are worried, most likely. Okay, you are talking right upper, left upper lobe, whatever you are talking. Okay, you are talking about air entry, which are big problems. You will see on the lung ultrasound, just now I mentioned 3 differences. The first difference is you will see nice mass. That mass with a clear boundaries. That is very important. Because in a pneumonia, you will see straight line, which is tough. That mass, which is a clear mass, and the air is not moving. You know that atelectasis means absolutely gone. Here is no issues. So the air is not moving or it's static is there. So what I'm trying to say that there is no fluid collection, the mass, no air bronchogram, and clear boundaries. That is the first point. Now, your question is about the blood flow. There are various, basically, what are the people what I encounter, or what I have seen the most of the ones which in our day-to-day practice. A lot of time I have seen increased blood flow. Again, the two of the patients what my resident has shown, sir, blood flow is not, I'm not able to differentiate these vessels, scales becoming problem, and the pixels are becoming problem. So we are at present moment, I'll just tell you the clinical fact. At present moment, we are giving a lot of value to the definitely examination and these 3 points. Blood flow, we always request our residents, put a blood flow, take a picture, take a video. So this is what at present moment we are doing. Yes, there is a big issues because two of the people article, if you see the professor, one of the article by Professor Daniel Duluca and one of the article by, I think, Nadia, they are saying, oh, there is a blood flow problem. Other people says there is increased blood flow, these people. So this is still issues, but I think we need more and more learning. These are learning curve for all of us.
Thank you.
So we have a question from Dr. Agyeman. What will be the lung ultrasound features if we have a combination of meconium aspiration and pneumonia, as they might be dual pathology?
Yeah. So Agyeman, see, first of all, I know as African countries, we always take meconium plus sepsis as a part. In India, we have slightly changed now because we are saying that, okay, we are coming out a little bit out of infection. We are taking meconium at present moment as a part of a chemical pneumonitis. But yes, you are saying meconium is there, congenital pneumonia is also there. Okay, you have diagnosed the pneumonia as one part. In the meconium, you will see the spared part. That means some part of the meconium is normal lung. What is normal lung? In the regions, the lungs are classic A lines. Some regions are classic A lines, but you should have a history of meconium. Now, only not meconium stain liker. There has to be clear-cut history. Okay, baby bad, required some ventilation, some sort of support, and then you got baby not cried. That history has to be there. Then that history with such spared areas, you label as meconium. And if you got pneumonia, then definitely you required additional antibiotics. That dual pathology, I can consider that at present. Yeah.
So there's a question. This is from Surjit and Alberto again. So different formulas for pleural effusion. And
yes.
Challenge from our perspective is studies are quite limited. In your practice, what do you recommend? Yeah. Okay. That's what I said. The formula. Yeah, I don't know. I can show that. See now, when you prefer to take the measurement from diaphragm. That means you have got liver picture. And then the fluid, sorry, I have mirror image myself. So when you got, suppose I'm saying the diaphragm, and then you got, okay, so diaphragm and you got the picture. From that picture, put a line till the end of the anechoic area. So what I'm trying to say that from end to end anechoic line, that's one line. And if you find a collapsed lung, from diaphragm to collapsed lung, that's the second line. I can show, just give me 1 minute if I have time. Absolutely fine. Please go ahead.
Just give me 1 minute. I will, so that they will enjoy more rather than discussing as a basic thought process. It's better to show the picture to them.
So just while Sir is sharing, if there are any other questions, you can either raise your hand or put them in the message box, please.
My screen is visible?
Yes, sir.
Yeah. So friends, now see. What I told you that, now see, just a minute, I'll just use the marker. Okay, identify the diaphragm. Can you see this diaphragm? This is the liver. So from diaphragm, measure this longitudinal, or you can measure the maximum depth. That's a one measurement. The second measure from diaphragm to the collapsed lung. That's a second measurement. So this measurement, these two are similar. This or this, whatever you prefer, you can take one measurement. This measurement plus this measurement multiplied by 70, or this measurement multiplied by 90 is the amount of the fluid. Is that okay? Or so I told you that from diaphragm to the maximum depth of anechoic area, prefer this, that's same. This is also 20 centimeter, this is also 20 centimeter. And from diaphragm to the collapsed lung, you can measure these two, that's a plus multiplied by 70. Or whenever you don't have this one, if you can't find this one, this is also acceptable. If you might not see this one. So maximum depth multiplied by 90 is the amount of the fluid which is there.
So that's really helpful. Just to emphasize for the people who are asking, is because the lung may be collapsed in different ways. That's why Sir has told us these two formulas. So fantastic. Sir, I've got a question from Dr. Ahmed Essawi. Dr. Essawi, are you able to unmute yourself, please?
Yeah.
Please go ahead.
Yes. Excellent presentation, sir. Thank you very much, sir. I have one question, sir. When the patient have pleural effusion, the diaphragm cannot identify the normal position, sir?
Sorry, Ahmed, can you repeat the question?
Okay, sir. When the patient have pleural effusion, diaphragm cannot identify the normal position, sir? When the patient have pleural effusion?
Hello, do you got the question? I'm not able to understand
No,
his question.
my gut feeling is he's saying that if you weren't able to, Dr. Ahmed, I think whenever you have a pleural effusion, the lung, there'll be atelectatic lung, which is compressive atelectasis. So you should be able to see the visceral and parietal pleura to give you measurements. He's kind of saying that if we can't see the diaphragm, but you should be able to see the diaphragm if you look, especially in the...
See, okay. Ahmed, the most
Yes.
important thing to diagnose the pleural effusion, you have to always go to the lateral scans.
Absolutely.
Yes.
You can't diagnose, you don't have to diagnose this pleural effusion through the anterior. You have to diagnose the lateral scan and the lateral lower scan. And the lateral lower scan, you should always see the first liver. You might see the kidney also, but at least liver, diaphragm, and then lung. These three pathology you have to see. That's what I should just now show you picture.
Yes.
Because that's a dependent part. The fluid will be accumulated on dependent part. Fluid will
Yes,
not be
sir.
upper part. Fluid is
Yes,
on the
sir.
lower part.
Yes.
So when it is the lower part, you should see your diaphragm. You should see your liver, diaphragm, lung. That's mandatory.
Yes, sir. Okay. Thank you very much, sir.
Yeah,
So
yeah.
that's the last question. I'm going to take this opportunity to thank you so much for what is an absolutely wonderful presentation. I think the beauty of it is we just do not see this kind of pathology. And I must confess, working in the Cornish in the UAE, I don't see this kind of pathology. So the benefits of being able to kind of see the images, but also look at the research that's coming out in terms of classification of severity of pneumonia, its presentation, which has therapeutic implications, is something that, is quite important. So I'd like to thank you on behalf of my group, but also all the participants from the NeoPOCUS family who are doing such a fantastic job. I'd also like to say that Sir runs a 6-month course, and this usually starts in January and September, and I cannot say enough about it. In terms of the learning for me, was huge. So for anybody, even from my group who's looking to get further kind of training, train in more detail with good peer review, it's highly recommended. God bless you, sir, and thank you so much.
Thank you, Alok. Thank you. Good night, everyone.
Thank you, everyone.
Friends, see you. Good night.
Thank you.
Thanks very much.
Thank you. Thank you. Thank you.